rash prophylaxis for all of your patients, what is it, and then what is your management strategy for rash?
I generally do, because even though the incidence of rash, again, tends to be lower than with some of the other agents, specifically with alpelisib, I find that using antihistamine, a non-sedating antihistamine like Claritin, is very effective in mitigating this toxicity. I think patients receive it well, and if the rash still develops, there are topical treatments, topical steroids that can be used, and of course there's the opportunity to get our dermatology colleagues involved if it gets more severe. But at the development of a higher grade rash, grade 2 or higher, we would actually hold the drug so that we allow the toxicity to decrease to grade 1 before re-challenging. There are also opportunities to intervene with other supportive therapies, as I mentioned.
Absolutely. And are you doing the same, Manali, using rash prophylaxis?
Yeah, I'm typically also using antihistamines, and the truth is so many patients are on antihistamines for other reasons, so it doesn't end up being a huge ask for them to continue or to even start a non-drowsy antihistamine. So absolutely, I think if that prevents the rash and allows for adherence to treatment, patients are more than willing to do that.
Absolutely. And I also use rash prophylaxis, and I think I like the point that you made earlier about educating our patients, particularly as it comes to diet, but I think we can do the same for rash. And I tend to use the 1% rule, right, where your palm is about 1% body surface area. Mm-hmm. And we ask all of our patients, if they are experiencing rash, to of course send pictures through the EMR and use that palm rule to try to estimate what their body surface area is, to your point, Reshma, to understand when we may need to hold or dose modify the drug as well.
I think it's also important to give them the heads up as to the timing of the onset. So the median time is tending to be a little bit longer than what we see with the diarrhea or the hyperglycemia. It's more on the order of like 12 days or so. That's also important to allow our APPs and our other members of the care team, so that when they receive that call, the important question is, well, when did they start the drug, and are we in that time period where they would be most likely to develop this toxicity?